next case, which is the mini HOLEP from Felipe Figueiredo, who was the creator of the technique. And we have the local moderators, Emiliano Peton from the Italian hospital in Bahia Blanca, Pablo Valladares for the Clínica Yunes in Santiago del Estero in Argentina, Rodrigo Juaneda from Sanatorio Allende in Córdoba, Argentina, and also Thomas Schier, I think that is here. Thomas, in order to moderate, please welcome. And also have the president of the Endourological Society Connected, Andreas Gross from Hamburg in Germany. And we have Fernando Gomez Sancha, the head of Clínica Centro in Madrid in Spain, Nicole Miller, the Department of Urology in Vanderbilt University in USA, and also Mehmet Ilker Gökce from Ankara University in Turkey. Thank you so much for the participation, and Felipe, go ahead with all the interaction with the new device that you have designed. Thank you and welcome.
So thank you very much, Alberto, for the invitation. It's an honor for me to be back in Buenos Aires with you. It's the second time I'm here, and today I'm going to show a minimally invasive laser enucleation for the prostate. So I like MILEP, not mini HOLEP, because we are going to use a 22 French resectoscope, and I would like to show some features. First, the outer sheet is 22, and there is two modifications. We asked them to create smaller holes to have less friction and no grater effect, the vegetable grater that can damage the urethra. And the second is that in the previous version, we had a ceramic tip that is connected in the metallic part, so the outflow is not effective in the first line of holes. So when we do the early apical release, the holes are inside of the sphincter, so there is no outflow. The pressure in the bladder goes high and you cannot see properly. So I asked them to create a modification of the inner sheath. As you can see here, can you zoom in here? We have a shorter tip and a metallic tip. And it has some grooves that allow me to have outflow since the first line of holes, because it's shorter. So the outflow is improved. And with the grooves, we have even less, we have an improved outflow from the tip between the sheets. This is brand new, is unique, is patented by RZ, and in my perspective, subjective perspective, it's a game changer, because in the worst part of the surgery, even with the 26, you have limited flow because of the outflow, because we are using resectoscope for TURP, but this is the first enucleoscope with improved outflow during the enucleation, especially the en-bloc enucleation. And the second is the morsoscope, because it's the only available morsoscope that fits the 22 French outer sheet without the adapter. So this is purpose-built, designed enucleation set. And the second thing is that we are going to use the brand new magneto cyber hole from Quanta System. It's 150 watt. I use the cyber hole in my hospital with the 100 watt. And this is my usual settings. I will stick to my usual settings because I'm trying to buy it, but not yet. And I'm going to start using high power in the yellow pedal and lower power in the blue pedal. In the high power, I will use a shorter pulse duration because I want more mechanical effect. And in the blue pedal, I will have a long, medium long pulse. With Quanta, we have the master pulse where I can choose 7 different pulse durations. And I like to use the 5th longest pulse. Because if I put the longest pulse is the vapor tunnel, I have excellent coagulation, but I miss a little bit of the mechanical effect. And here I can have a combination of good mechanical effect and excellent hemostasis. And at the base, I will show the virtual basket and the vapor tunnel. And at last, I will show the magneto and compare the single standard short pulse with the magneto to show the difference in the quality of the coagulation. So let's start it. I'll remove the second glove. So Norberto, I
Felipe,
can say that I'm really honored to have so much experience in nucleation as moderator.
Felipe,
We have people
give
from
us
different
just
continents.
a few seconds for the presentation of your case in order to start. Be prepared to start, and we
Perfect.
will do the presentation of the case. Go ahead.
Bueno, la presentación se trata de un paciente masculino de 56 años de edad, con un índice de masa corporal de 30. Como antecedentes personales, el paciente es hipertenso, diabético tipo 2, tuvo una nefrectomía radical derecha en el 2022, con una anatomía patológica para un carcinoma de células claras. El paciente intercurrió con una retención aguda de orina y requerimiento de colocación de una sonda vesical, y el PSA control fue de 10. La resonancia magnética nos informa un PRATS 2. Vemos el corte coronal a continuación, con un volumen prostático total de 70 gramos. El urocultivo es positivo para un Proteus mirabilis, recibirá antibiótico previo a este procedimiento, la función renal es conservada y el examen dígito rectal no presenta sospecha de malignidad.
Could you hear us?
Norberto, can you hear me?
Yes,
Yeah, I
you
can
are
hear
in
you.
contact
Can you
with
hear
all
me?
the moderators now.
Perfect, perfect. So I'd like to say hello to Fernando, Mehmet, Nicole, Andreas, and all the moderators. Thank you very much for joining us. I hope not to disappoint you. This patient has a catheter, so I'd like to show how easily it is to enter the natus with the 22. In this case, the urethra is dilated with the catheter. He was wearing a catheter for a few months. And even in the sphincter area, it's very smooth introduction. We have a nice atraumatic procedure. And this is good for prevention of urethral trauma, which can impact the stricture rates, and also in the lateral movements during the apical dissection that can prevent the incontinence when using the 22 French sheath. And we see it's a 70-gram prostate, the two lateral lobes, and into the bladder, we see some hair. Tuberculated bladder. Lucia, can we empty the bladder? Lucia, podemos vaciar la vejiga? I'll try to aspirate that hair with the morcellator.
Felipe, hello. This
So
is
we don't
Fernando.
lose time, and we can start the procedure.
Can you hear me, Felipe?
So I like to use the medium long pulse at the apex because the holes in the outer sheet are obstructed in the, let me adjust the fiber, inside of the sphincter. So here we are inside of the sphincter, we have poor outflow. But as you can see, we have good outflow because of the new inner sheet, even inside of the sphincter. So let's start around the veromontano. This is the easiest place to find the plane because that belongs to the capsule. Everything is adenoma, and the scope of the capsule is the veromontano. So if we cut around the veromontano, we can easily find the anatomical plane. One of the possible criticism of the new sheet is that we couldn't have good flow. But the inflow is as good as 26, and the outflow was the limitation for the flow, because once you increase the pressure, you limit your inflow. So the key to have good flow is to have good outflow. And this is something we try to address with this new design of the inner sheath. Because even with the 26, when you are doing the apical dissection, especially the white line, we don't have a lot of space to allow the flow to come through the holes in the outer sheath.
Felipe, this is Fernando. Can you hear me?
So finding the plane under the lateral apex allows you to create some tension in the mucosa of the sphincter that shows you the best place to cut the sphincter. So for me, I tried different techniques during my learning curve. There wasn't many people doing HOLEPs in Brazil. I was one of the first. And I started entering the plane here and lifting the lateral lobe without incising the mucosa. And I would face a lot of transient incontinence in my first 50 to 80 cases. And something changed dramatically when I started to incise the mucosa before
Felipe, could you hear
tearing
us?
on each side of the barrel.
Felipe, could you
Yes,
hear
I'm
us?
better.
Felipe?
Yes, I can hear you.
Yes, Fernando have a question for you.
Please,
Hello,
Fernando.
Felipe.
Hello, Fernando.
I am
Nice to
wondering,
hear you.
congratulations for the idea. It looks brilliant, the idea of improving the flow in very, very restricted spaces. Finally, someone is thinking about a specific instrument for the job. So congratulations. The question is,
Thank you very much.
do you always use 22 French, or you find cases where it's not enough? Like, what is the percentage of cases you do with the 22 French scope? Do you have to upgrade to
Actually,
a bigger size?
No, in my hospital, I don't do 26 French surgery anymore. So I have 22 in 1/3 of my cases, and in 2/3, I'm using 18 French. If the prostate is less than 80 grams, I will do an 80 French enucleation, and then I change to 22 just for more salation. Because most of the damage to the sphincter and to the urethra is with the movements of the nucleation phase. So I believe we can reduce even more the trauma to the sphincter, to the urethra using 18 French. I think that the only situation that I still use 26 is if a patient has a penile prosthesis. With a semi-rigid penile prosthesis, which is very common in Brazil, we don't have many inflatable prostheses. The resectoscope is too short, and we cannot reach the bladder length. So there is an extra long resectoscope from RZ, but it's only available in 26. I have it, but currently I only use in this kind of patients. It's maybe 1 or 2 times a year. And I start with the 22. I try to enucleate as much as I can. Usually I can reach the apex, and then I have to change to 26 to complete. In this case, I always offer the patient to put a catheter 7 days before the surgery to have an atraumatic dilation of the urethra. 6. So
Felipe,
the only situation is if I put the catheter before, like a double J, to have an access sheet. Yes, no, Roberto.
Felipe, Pablo, ¿cómo estás? Antes que progreses, quería saber si la modificación que hiciste en el extremo distal del equipo mejora el flujo de salida o de entrada, o ambas.
Ambas, ¿por qué? La verdad, can I answer in English, Pablo?
Sí. Sí, en inglés.
Porque when you enter the irrigation, the pressure inside of the bladder increases. When the pressure inside of the bladder is equal to the height of the bags, there is no inflow. So the limitation for the inflow is not the size of the scope, is the amount of outflow that you have. So to increase the inflow, we have to increase the outflow. And this is what I try to address with this new design of the inner sheath.
Porque
So-
con la vaina actual que usamos para nuclear, de 22, la visión se dificulta muchas veces cuando hay presión a través del esfínter, cuando uno está en la primera parte de la cirugía. Me parece
Exactamente. Nesta parte, muitas vezes estamos com o equipo dentro do esfíncter, aqui. E não é outflow, porque os furitos da vaina externa estão obstruídos. Agora, mira, há duas maneiras de fazer a liberação temprana do esfíncter. The white line, you start to find the plane. I like to find the plane to see the contour of the capsule and then make the progressive cut of the mucosa. The progressive cut should move a little bit forward because of the shape of the sphincter. If you cut like here, you will resect part of the sphincter. If you lift the apex without incising the mucosa, you tear the mucosa here. And with this tear, you have early incontinence. So we finished the early apical liberation this left side, and we are going to liberate the right side, the right lobe. So we enter under the apex. And another thing is that I believe that the smaller sheets allow you to enter more easily in tight spaces. So sometimes the big sheet is difficult to get under a small amount of tissue. And with the 22, it's a little bit easier. With the 22, you have excellent irrigation. You can move higher in energy. I try different settings, and I like with 1.2, I can have a closer working distance, you know. But I have to work a little bit further from the tissue.
En cuanto a la técnica,
You see here,
Felipe, en cuanto a la técnica, me gustaría preguntarle al doctor Fernando si nota mayor diferencia en la movilización de la glándula cuando hay glándulas muy voluminosas, cuando hay liberación de la cara posterior primero.
No entiendo bien la pregunta.
Sí, porque antes veía que hacía liberación para ingresar al para liberar el esfínter y los apicales, veía que hacía incisiones de descarga. Ahora veo que
Sí, correcto.
Ahora veo que hace más liberaciones de la cara posterior de la próstata y eso le genera mayor movilidad. ¿Podría ser así?
I'm going to answer in English because Mehmet is not capturing the concept.
Sí, sí.
Yes, I still do access incisions at the apex. You know, sometimes the space is very restricted and you have to incise a little bit, and even cutting somewhat into the adenoma to get a little bit better access. But then, of course, you're going to follow the proper plane. And what I understand, and let's see what Felipe thinks, is that this is an operation that needs to mobilize the adenoma progressively and also strategically, you know. So sometimes you cannot enter easily the anterior part of the apex if you haven't mobilized, let's say, deep enough. So I think it's important to think in terms of strategic development and mobilization of the adenoma, because this is what is going to give you access without having to put traction on the sphincter. So one example, and Felipe, tell me what you think. One example is when you try to do the 12 o'clock incision in a 3-lobe technique, the scope has to be tilted up. So you have to push down with your hands to reach the 12 o'clock. But when we see Felipe entering the bladder at 12 o'clock, we will see that his scope is totally horizontal, which means that there's much less traction at the sphincter area. And this is because the prostate has been mobilized and the endoscope can push the tip of the adenoma down. What do you think, Felipe? Do you
I
follow?
completely agree with Fernando. Yes, yes. And I also agree that we don't know which kind of trauma we are inflicting at the sphincter. And there is traction, there is tearing of the integrity of the circular aspect of the mucosa. We know from anatomy publications that there are smooth muscular fibers that are very closely related to the mucosa of the sphincter. So the way you treat the mucosa is the way you're treating the sphincter. And extreme movements of your hands can cause also trauma to the sphincter. And one of the advantages of the block is once you get over the adenoma, you are pushing the adenoma down, and then you bring the capsule down. And this avoids extreme movements like pushing your hand to the edge of the table, which I believe it can inflict damage to the sphincter. So we see here, I release both sides, and I left a little bit of mucosa here. Why? Because I believe that this mucosa should be a little bit longer anteriorly than posteriorly. So here, remaining apical adenoma. And once I release it anteriorly on both sides, I will cut this final flap. This is a slightly modification of the publication from 2020 that we published in Andrologia, and is available as a free access in Urology Video Journal in the Mehmet paper. So today I like to leave because one of the awkward things that can happen if you leave a longer anterior mucosa is that sometimes this mucosa will detach and be hanging here, obstructing. And especially during this ascending incision of the at 12 o'clock. So if you avoid crossing the midline, you are able to dissect the anterior part of the apex and the mucosa is still attached. So it's the way that I have found to prevent this kind of tearing of the mucosa. Because sometimes it's easy, sometimes in obese patient, in big gland, it's very challenging to go above the adenoma. And with this strategic, as Fernando said, you have to find your strategy to have consistent results. You can have the perfect aspect of the mucosa in some cases, but the idea is to develop a technique that allows you to have the perfect sphincter every single time, or at least 99% of the times. And I believe that this modification
Felipe,
allowed me to achieve that.
You know that Humphreys has published a very interesting study. He published 2 recent papers. One of them comparing en bloc an early apical release with their traditional 3-lobe technique. And they have stated that their immediate incontinence rate is lower when they do early apical release. But the other study, which I think is very interesting and it supports very much what you're saying, is that when they finish the operation, they look at the sphincter and they grade the degree of damage to the sphincter. So grade 0 means that the sphincter is perfectly preserved with all the mucosa. Grade 1 would be longitudinal damage to the mucosa, things like that. So, and they saw a perfect correlation of the preservation of the mucosa with immediate postoperative continence. So I think now we have a proof that when you respect the mucosa, you of course are protecting immediate continence.
I completely agree. I have this paper. I think this was a beautiful and brilliant demonstration of something that we have been saying for a few years. I saw this dramatic decrease in my transient incontinence rates after starting the early apical release, but eventually I would have some kind of damage to the integrity of the mucosa. So not only the early apical release, but small details that can improve the chance of having a grade 0 sphincter at the end of the nucleation, which is not very easy in obese patients. Up to now, I can achieve it in most of my cases of smaller glands and smaller slim patients. But if the patient is very obese, it's quite challenging to achieve that because you have less mobility. You cannot go above the adenoma without putting pressure against the pubis. So this kind of traction is not good for the sphincter and for the immediate continence. And the final aspect of the sphincter is an easy and immediate way to reflect that kind of trauma.
I think that in obese patients, when the access is difficult to the anterior part, you need to release more towards the bladder neck, the posterior and the lateral aspects before trying to climb anteriorly. But Felipe, one question.
This is something I do too.
How do you think the smaller caliber of the endoscope influences, for example, surgical time? Because my question is, or my wonder, what I wonder, if you see Mehmet operating and doing HOLEP, he's probably using a bigger caliber scope, no, Mehmet? But he's extremely fast. And I don't know how the smaller size scope influences surgical time, because there must be a trade-off between, let's say, a smaller caliber instrument is probably better, but if using a smaller caliber instrument means that you're going to stay much longer in the urethra, that might, let's say, remove some of the benefits. No? What is your thought about this?
This is something that was addressed by our friend Mario Sofer in Tel Aviv. He has made a match pair analysis, same surgeon with 26 and 22. And he found the same surgical time with the 22 than with the 26. So in his hands, it was the same. I honestly cannot tell you the difference because I don't use 26. I don't have a comparison. I'm sorry, my outflow stopcock was closed. So you see, when you close the outflow, you reduce the quality of the image. So I cannot tell you if I would be faster with the 26. I think you are faster if you use high I think.
Felipe, Pablo.
Setting. Por favor, Norberto.
No, bueno, quería contestar, a ver si le sirve al profesor Fernando, que en mi caso tengo hechas más de 100 próstatas con el Mini y creo que la velocidad con la que se opera es independiente del tamaño del equipo. No he visto que haber retardado más la cirugía por el tamaño, por el calibre del equipo.
Felipe.
Pablo is saying, por favor.
Do you hear me, Felipe?
Yeah. Emiliano?
This is Rodrigo. Juaneda, congratulations on your beautiful surgery and your great job. One question, when moving from standard to slim HOLEP, the 2.9 optic is more fragile, obviously. What tips can you give us in order to protect, especially in bigger sizes and in obese patients?
Yeah, maybe the only two criticisms, the cons of the system, is that the 2.9 scope is more fragile. Okay, so if you put a lot of lever of angular force in the scope in obese patients and in massive glands, you may break the scope. So to preserve the scope, you have two options. First is to be more gentle in your technique. It's something you have to work on with time. And when you have to do force, you cannot do force in the camera, because the weak part of the system is the working element, where we have just a small tube and the scope. This is where it breaks. we have no mobility of the glass part of the lens. So if you have to do force, you have to hold the sheet, not the camera, so you can do the force. The second thing is that you can select, if the patient is very obese, you'd want to use the 22 French. I don't do that in my hospital. What I do is that I'm only working with private patients. So if it's a massive gland, my cost is different because it may break my scope. So I charge a little bit more so I can cover, use it in every single case. Because for me, it's a headache if I found a small urethra, which is very common in Brazil, and then I have to do some kind of dilation, urethrotomy, and if the patient has a stricture, I don't have the skills to do a uretroplasty. I have to bring someone from other city to operate, and it's extremely frustrating for me. Well, I would rather risk to break my scope than have a urethrotrauma. This is a philosophy, a principle. Maybe this would not apply in a high volume public hospital where your integrity of the scope may be the difference between operating hundreds of cases per month or not. But in the private sector, you can adjust this fragility of the scope by charging a little bit more. And this extra price will cover the lower longevity of the scope. And the second is that the scopes are not more expensive. You know, the 22 is the same price of the standard. So even a bit cheaper than the most famous brands. So I don't think cost is an issue. We are doing robotic surgery, we are doing very expensive procedures, and I think the benefit that we can achieve in terms of safety is higher than the higher cost that we are using. Pablo has done over 100 cases in north of Argentina using the same scope. How many times has you broke your scope, Valladares? I have broken scopes in massive glands.
Creo que ahora ha llegado a su fin, pero la diferencia que uno nota al realizar la cirugía con el mini es que la preservación de la mucosa y la continencia inmediata es mejor. ¿Por qué? Porque uno se dedica a preservar, a cuidar el equipo, y eso creo que da una ventaja con respecto a la continencia inmediata.
Sí, eso, I believe this is another advantage. As you may break your scope, you try to be more gentle in your surgery, which will benefit the patient, you know. You don't want to have a very aggressive technique, think only about the time. You want to have a gentle technique because you are worried with your sphincter. It's closing my outflow. So I will change the setting right now. Please, Karina. We will increase the energy to those.
Felipe, this is Mehmet from Ankara.
Hello, settings. Hello, Mehmet. Nice talking to you.
Felipe, I want to make a comment on Fernando's question about the speed of the procedure with the MILEP.
Okay.
Personally, now I'm a fan of the MILEP, the Slim HOLEP 22. It's really a great invention. I'd like to congratulate you. The thing that changed in my practice is I usually work with very high energy settings, like 3 joules during nucleation with the 26 French standard scope. But with MILEP, as with your advice, I dropped the energy to around 2 joules as you use here. So with the 3 joules, I have bigger pulses, so I can be a bit faster. But in the end, if you just use the same energy levels with the Slim HOLEP and the standards, I don't think it will make a lot of difference because you irrigate a very small space between the adenoma and the capsule, either with 26 or 22, it doesn't make a lot of difference. But the difference in my hands comes from the differences in the laser settings with the decreased energy with the Slim HOLEP.
my impression is that when we are dissecting the sphincter, the outflow is reduced, and even with the 26, you should not use so many energy because you have a poor vision and you may burn your scope, you may... I think it's better to use lower energy until you release the mucosa. Okay? Once you release the mucosa, you can go higher because you have all the holes in the outer sheath working with the outflow. And maybe, I don't know, but with this new device, the new inner sheath, we have improved outflow. You can go higher, 2.5 or maybe 3 joules. I know Martin can in Berlin, and he used high power like you, Mehmet. I don't know if Martin is in the audience, if he can comment his experience with more energy per pulse, like 2.5, 3 joules. Martin is there?
Yes, I'm here, Felipe. Great job you're
And
doing.
Do you use more energy?
Yes, I use a hybrid setting, which is 3 joules, 40 hertz on the left on the yellow panel, and 1.5 joules, 40 hertz on the blue. And I use the blue in the apex, and then in the plane I speed up with the high setting, and I have no problems. I use it in 26 and also in the 22 without any noticing of problems. So
I think this answers your question, Mehmet. You can use your higher energy at the base.
Yep.
Final part of creation. Like now, I'm using 2 joules right now. I'm using vapor tunnel. Vapor tunnel is one of the pulse modulations of the Quanta system, which has a long pulse, a very long pulse. And I think it's better for this kind of incision and vaporization of residual adenoma, and it's good for hemostasis. Today, I will use for the first time Magneto for the final hemostasis, but Magneto was specifically designed to copy the TFL effect in dusting for flexible ureteroscopy. And we can only achieve 1 joule 30 hertz, which is a very low power for HOLEP. I don't like to use such a low power for HOLEP, so I will use Magneto after the nucleation, just for final hemostasis, so we can compare this effect for hemostasis. You can see the vapor tunnel has excellent vaporization properties. This is something I learned last year in Neurovivo. Norberto invited me to moderate Martin Kahn's HOLEP, and I saw the effect of the long pulse, and I tried it the same day, and I was like surprised how good it was to incise this mucosa. And since last year's Neurovivo, I adopted this setting. Vapor tunnel, 2 joules, 40 hertz at the base. Once I see the vertical fibers of the bladder submucosa, I change to the vapor tunnel. I like to use the vapor tunnel too for this incision of the adenoma. I know Fernando doesn't like this incision, but I think it gets more mobility of the adenoma when I'm dissecting the posterior aspect of the bladder neck. And something that is much easier now that I have completely coagulated the blood supply of the adenoma. Laterally, I have already reached the 5 and 7 o'clock position. Bloodless, this incision right now. And only with one incision, even without removing the median lobe, you can achieve a greater mobility to finish the lateral dissection of the posterior bladder neck. I use this incision in probably 90% of my cases. Sometimes in small prostates, you can connect both sides more easily, so you don't need to go like this.
Felipe.
I think the dissection on this side is a little bit deeper, maybe a little bit into the peripheral zone.
They're all working out.
Yes,
Felipe?
Norberto?
Tom
I
Shi,
also
Felipe.
like this 5 o'clock incision for the
Hello,
posterior
Tom.
part. with MILEP.
I'm sorry, I couldn't hear. Can you repeat the question?
I also like this 5 o'clock incision with MILEP. During the MILEP procedure, I do the same 5 o'clock incision. It really helps a lot.
I agree, completely agree with you. I think en bloc is the way to do it because we have symmetry, we have a smaller cavity to allow to have the flush out of any bleeding. You don't collect blood into the bladder, but one of the disadvantages of the en bloc is for the dissection of the posterior bladder neck. Because the adenoma, when you push from one side, it hits the capsule on the other side. And then you cannot create the correct traction to finish this part of the surgery. And with that incision, the lobes, they are pushed one over the other because you get this mobility between the lobes. So you can reach further. And then it's just a small amount of tissue to have some degree of inflammation because the patient was with a catheter for 4 months.
Felipe,
Felipe,
can I ask you your approach?
it's not that I don't like the 5 o'clock incision. I think, as I said before, you have to be extremely strategic, mobilizing the adenoma to have reach to this area. And in my opinion, I don't find it necessary in the majority of cases. One thing that I find very, very useful is if you come from both sides and you get the 6 o'clock attachment smaller and smaller, there comes a moment when you can lift a little bit, for example, the left lobe, and then tilt it into the bladder. So that removing half of the adenoma from the cavity, once the pedicle is limited, gives you excellent access, and then you can finish. And I think, in my experience, is not an absolute necessity. Of course, I understand that you need to be very, very thoughtful, and you need to develop the experience to be able to sequence your dissection in a way that will give you progressively better and better access. And then finally, this tilting of the adenoma, the fact that, some people say that en bloc has a problem because the bladder neck is usually thinner or smaller, less wide than the adenoma, and then it's difficult to tilt the adenoma into the bladder. But in my experience, rotational movement, so pushing one lobe first and then continue the same rotational movement to finalize the case, makes it very, very, very pleasant and very nice. So just a comment.
I like to push one of the lobes into the bladder to create space. And with that space, it's much easier to release the second side. But I think in my hands that when I do this incision, it's easier to push the adenoma without damaging the bladder neck. Because if you haven't released completely this lobe, sometimes even small attachments to the bladder neck can allow you to perforate by traction. So I try to do what you do,
Yes.
but I was not very successful because when I push, like here, if I push the lobe into the bladder, I create a perforation, not with the laser, but with the traction. So I realized that the problem was the traction. How can I reduce traction? With these incisions. So this incision is something like you spend a little bit of time, maybe a couple or 5 minutes to do the incision in the proper depth. And I know that in some healthcare systems, every second in the OR costs around $1, like in the US, in Switzerland. But I think you save time in the end. It's like an investment. You invest 5 minutes to make the incision, and then you can get a faster enucleation of the posterior aspect of the bladder neck. So you get your time back.
Another comment, Felipe. I will get your MILEP instrument when you remove the Kunz element. It still
You
resembles
remove
a
what?
resectoscope.
Uh,
Did you hear it?
I don't know if I understood the joke, but
Yes, I will buy the instruments, the MILEP instruments, when you remove the Kunz element.
Yeah, actually, I use the Kunz working element regularly, so it was very easy for me to adapt to MILEP. But you're right, when if
I'm
you don't
asking-
like to use it, it's going to be a problem.
I know Fernando don't like the working element. He used the bridge, which
Yes,
is
I tease Felipe. I tease
something-
Felipe.
yeah. And actually, I'm using a bridge to be able to inject triamcinolone at the bladder neck at the end in small glands. One of the things that happen in my practice is that with the smaller scope, especially with the 18, younger patients and smaller glands are coming to me for MILEP. So when I started, I would only operate big glands, anticoagulated patients. This is the life of the nucleators. But with MILEP, people in the 40s, they're coming, okay, I'm waking up at night. My father had a catheter before his surgery. I feel that I'm not voiding well. I want to be cured. Can you cure my BPH? I say, yes. BPH is curable. You just have to remove all the adenoma. How many kids you have? 3. Do you want more kids? No. So I have the pressure for you. I'll remove all the adenoma with this small scope. And then I show the 26, the 22, and the 18. They said, okay, I want the 18. But no, but 22 has a better flow. I don't care. I want the 18. That's why I use the 18 in most of my cases. If you have in your office the 3 sheets, people will specifically ask for the 18. They don't care if you don't have an RCT. They see with their eyes, and they believe their eyes more than science. And hopefully, Martin will present data in an RCT, MILEP versus 26 HOLEP soon. I think another center that is doing this RCT is Mario Sofer in Tel Aviv. And then we will have level 1 data to support what we already know in our his previous papers. And from the audience, from the moderators, now I think MILEP is already the majority. We have Pablo doing MILEPs, Emiliano, we have Martin, Norberto, here I have Jorge Aguilar doing MILEPs, Lucas Irula. So Fernando, we need you in our team. You are our goal scorer.
Remove the bridge.
You cannot be playing
So,
into
Felipe,
the other team, you know.
Another,
like Real Madrid.
Another question. How do you think, I mean, how much relevance do you think that the addition of the magneto setting is going to be for BPH?
I think the idea is nice, but magneto has a very, very long pulse. And the problem, can you open the irrigation, please? And the problem is that we cannot achieve, I don't have irrigation.
Okay, the tube is
The problem
collapsing.
of magneto is that the pulse is so long. The pulse is so long that you cannot achieve the same power of the vapor tunnel that I'm using right now. So I hear people saying, oh, tunnel fiber laser has a much better coagulation profile. I didn't see any blood up to now. This patient has a catheter for 4 months, is an inflamed prostate. So I think if you use the proper hemostatic technique, the first pass hemostasis, and you have the new pulse modulations available, I don't think that Homium loses for TFL in terms of hemostasis. I know other people say differently. We have the Dimitri. I did a 2-flap recently, and it's much slower. We cannot achieve the power that we can achieve with the new Homium machines. And I have the 100-watt Homium at my house, but I'm looking forward to have the 150 because I will dramatically improve my surgical speed using more energy. So maybe I will soon work like Fernando with 100 or even 120 like Martin and Mehmet, because with my current machine I cannot do that. So I cannot say that, oh, you cannot use it with the MILEP set. My current laser doesn't allow me to give 120 watts. I can achieve 80 watts with the 100 watt laser. Otherwise, I would have to use like 3.5 joules. So with 2 joules, I can achieve 80 watts. And soon, when I get my magneto at home, I will probably increase my, because the problem with HOLEP is that you start doing 1 case per day, and then 2 cases per day, and now I'm doing 3, sometimes 4 cases per day, and Fernando is doing 6 cases per day. When he goes to Sofia, 10 per day. So every 10 minutes makes a huge difference, and I think it's not about the sheet, it's about the outflow. And the speed is not related to the endoscope, but related to the amount of energy that you use. So I think except at the apex that we should use less energy because you have less flow. At the base you can go higher. Even now, Luca, can you put 50 here? 50, yes.
Felipe, Tom Chi, just one question from my end. It seems like with miniaturization, one of the advantages oftentimes is that people can get sent home sooner, or they have less pain or discomfort afterwards. Same-day HOLEP is obviously a big trend now. What kind of impact on those factors has miniaturization done in your hands?
What I see is that I have... 1 minute, Thomas. Thank you. So now, Fernando, I'm using 100 watts. So I don't see a big difference in the quality of the image. You can use it. I'm using vapor tunnel, okay? Not the virtual basket, because I think it's a softer incision and dissection. And especially at the posterior bladder neck, I have less mechanical effect, so I don't perforate. But this is excellent for vaporization. So I think you can
Felipe.
use 100 watt, Fernando, with the
Emiliano.
new inner sheet. About Thomas, you're answering your question. My impression when I moved to 22 is that the early symptoms, the first week, has dramatically improved. Some patients, they don't take one analgesic pill in the first week because we have no retrotrauma. You don't have to dilate with Van Buren sound. You don't have to use Otis. So I think you can improve the outcomes in the first week. After 3 weeks, they start to complain of dysuria because there is an inflammatory reaction at the fossa. All the coagulated areas that we have will create a fibrin layer, and inflammatory cells will come to digest this fibrin. So the peak of my symptoms is in 40 days after surgery. And it improves slowly after that. We have small bleeders that I will address.
Felipe.
We have an empty fossa, we have the adenoma into the bladder.
Felipe.
So I'm not so fast like Fernando, but how long did it take for the surgery, Norberto?
Felipe, Emiliano, placer falar con você.
Por favor, Emiliano.
What are your main tips for us who are starting to do MILEP? Your main tips.
Main tips. I think not only for MILEP, but also for HOLEP, the main tips are always think about the sphincter. Okay? So even if you are working here, you have to think what's happening in the sphincter. sometimes to achieve a hemostasis at the anterior bladder neck, you push the scope against the sphincter and then you damage the sphincter against the pubis. So if you are doing too much force with your hands, your sphincter is having the same force. So you have to change the strategy. If you cannot reach the anterior bladder neck, maybe you cannot do force. You stop, you empty the bladder, and then you can reach. I don't like to empty the bladder before the morcellation because I think that you have a very clear urine inside of the bladder. If I empty, I may have a problem in the morcellation, okay? So I only do the final hemostasis after the morcellation. Let's show the magneto 3.
Felipe, I think it's a good idea
One.
when you enter the bladder and you still have most of the bladder neck attached to the adenoma. And when you do the anterior cut, I think it's a good idea to do the hemostasis of the anterior mucosa then, because still you can push the adenoma down and the bladder neck will come to you rather than having to force the endoscope
Yes,
too much.
this
if
is
you know what I mean.
critical, and I recommend you to do that in all the cases. But after the nucleation, when you push the adenoma into the bladder, you did your hemostasis. But sometimes you have some bleeders at the mucosa of the bladder, especially in big glands. Sometimes we have varicose veins in the bladder. And then if it bleeds after you push the adenoma, you don't have this traction anymore. So how can you reach it? So the first thing I would recommend is not to make too much force against the sphincter. You should empty the bladder to reach the anterior bladder neck. Okay?
Felipe,
Me-
Felipe, we will
Yes.
share the screens because we are already connected with Milano, and I will invite
Perfect.
moderators, the local moderator for the robotic surgery, in order to share the screens all together. Stay there. You stay there. I want to invite Juan Manuel Alvarez from Mar del Plata and Marcelo Featherstone. Please come